So, hi, good afternoon, everyone.
Good afternoon,
Lazy Sunday afternoon for everyone else than us, because we are still, with all the days being blurred by the lockdown, we are trying to nail with this COVID situation, both in terms of uh, medical expertise as well as shortage of almost everything, particularly the manpower and the PPEs itself. Initially, Kolkata took its own time to catch it up, uh, but now I think we are also in the forefront, like the rest of the big cities, big metros of India, where we are getting. And with the lockdown approaching towards its end, 4.0 will be applicable. I think all of us will get a small number. Initially, it was mostly the government sector hospitals managing patients, but now the private sector patients, particularly the hospitals which were specified at COVID hospitals, they are managing more patients, and the hospitals which were not specified at COVID hospitals, they are actually getting COVID patients. And my estimate or calculative guess is that in another couple of weeks to months, every one of us have to manage COVID patients, whether uh, knowingly as well as obviously unknowingly too. And Kolkata initially was little redundant on eventually we are now more number of labs coming up with the test with different technologies, with RT-PCR, with TrueNAT, with the gene expression and all others. And now the turnaround time for getting the test is lesser than what we started. Still, we have a long way to go. And we also learned many things down the line from, obviously, from the WhatsApp knowledge store, from internet, from the innumerable webinars, right? Which is now a little bit pain in everywhere. But this webinar, that's why we wanted it to be more of an experience sharing rather than being preached. So the idea of ISTCM Kolkata is to bring in everyone who's managing patients in different hospitals of Kolkata and outside, and we share our knowledge, we share critical issues, we share uh, everything. One thing before we begin, I think I am audible to everyone, is that the camaraderie and then the networking, the the helping attitude that we have received all colleagues in times of COVID, in particularly in critical care, is amazing. We were never shy of coming forward. We were never afraid of this disease. All of us worked. In fact, this is the one of the few specialties which work fully. I have not seen the critical care colleagues of mine who say that I'm not well, I'm not well. Every one of us came forward, and every one of us is helping the other person. I have personally arranged shifting of patients to different hospitals, and we have actually sort of surpassed ourselves by treating others' patients, not doing a little bit of uh, sort of deconstructive criticism of our colleagues and all others. And I think till date we are doing fine as of now. So I will start. I think Suresh joined. Suresh, one of you joined. We will, by the agenda, going by the agenda, the first three speakers were Sushruta, Suresh, or Tanmay. So if they are not there, if Dr. Kole and Dr. Paja has joined, I will ask them to go for.
And fear of COVID-19 has swept through the world as a wildfire. Almost 5 million people infected, and also more than 3 lakh people died. So India also is witnessing the massive upsurge of COVID-19 patients. in our state of West Bengal, many eminent doctors who are present here with us today are fighting this disease day and night. This webinar is a golden opportunity for us to learn from the experiences of the people on the front line of the battle and exchange. We have here the people who are working on the front line, and at the same time feel that the management of COVID-19 is relatively new and it is changing in a rapid pace. So arising from the previous and ongoing experiences, we are realizing it. And also I firmly believe that it is of paramount importance to be updated regarding this continuously changing landscape of COVID-19 management. I am sure this webinar will definitely impart to us a significant amount of salient knowledge. And in fact, in this current scenario, since physical meetings cannot take place, ICCM Kolkata will be regularly organizing this kind of webinar. I sincerely hope that everyone present here.
Good afternoon, everybody. Achha, first of all, Dr. Soren Paja, I am welcoming on behalf of ISCCM Kolkata as Secretary of the Kolkata branch. And I think last 2-3 months, we are basically struggling with this corona infection. In the initial part, there were so many webinar was going on in different format, different areas, different part of the country, that people was dying. That time there was a caption that, okay, people are dying more with webinar than actually with COVID. So that's why initially, and that time actually in Calcutta also the number, and West Bengal, the total number of corona infection was not that much. Gradually, this number in India is increasing side by side. In Calcutta also last 2 weeks, almost there are 80 to 100 cases per day, and I think hopefully once the lockdown is over, so definitely in 2-3 days after, we will get say approximately 150 to 200 cases maybe. This is what we are thinking, because whatever is the reports and in records, that number may go up, because in the hospital, in our hospital, initially it was started as non-COVID hospital, but more or less last 2-3 days, every day we are getting 2 to 3 cases per day. So obviously, those hospital dealing with the COVID, the numbers will increase. And today, this is the, our COVID session. We are keeping more towards our means Calcutta and West Bengal scenario. Not only that, what is our experience? Because day by day, we are basically getting too many informations. Every day there will be 10 to 15 different articles, different small your kind of experience. So this type of the data are coming. So with that, so our understanding are increasing, and keeping in that mind, today's focus is what is our experience in this Calcutta, West Bengal per se, as well as there are also different guidelines are coming up. Basically for that, there are state guidelines, there are ICMR guidelines also. So question is, which guidelines we should follow, that can be discussed, and what are the guidelines that has been framed in our guidelines. There are Dr. Vibhuti Saha, Dr. Sugato, Dr. Asutosh Da. So all of them actually was in that guidelines, and also Orindam was also part of some of the training program that is happening in the West Bengal state. So considering that, we have kept those topics in that, and there are some hospitals like Apollo, Fortis, your AMRI, this Medica, and other hospitals, they are also managing actively for this COVID infection. So that's why we have kept some of the experts from those hospitals and about their experience sharing. So that's why today what we are doing as moderator, there will be Dr. Saurabh Kole. He is our chairman of the ISCCM Society. Then there are, as you have gone through the whole list of our faculty members. So all the faculties, they will cover different aspects of the year. Only one little change, what I think maybe today we can think of that change. So Calcutta experience, they will initially briefly describe about their patient profile and other thing. And usually 5 to 6 minutes, I will request initially as sharing their experience. But finally at the end, all these experts should be there, should be part of their the discussion. about the ventilatory management, what are the difficulties they are facing, and what are the defined protocols they are following also. Because sometimes there are patients who are not responding to the usual ICMR as well as the West Bengal guidelines treatment plan. So that's why those discussions should be there in the later part of the year. I will request all of the audience to be part of that discussion. They should send their questions so that can be discussed here. And there is one spelling mistake, that is in the name of Dr. Sugato. Sugato, actually it was Sogato, not Sogato, it will be Sugato. So that was, I just noticed later on. So I am personally apologizing for that. And without any delay, I will request our two moderator, Dr. Saurabh Kole, to start the session. And first we will, after Dr. Saurabh Kole, then or Dr. Arindam will start about our Calcutta and West Bengal, the COVID scenario. So I welcome you. I hope this discussion will be, I think, fruitful. And after that, in the coming Sunday, we will keep it at edition 2. So that I will also request you to also attend that, because that will cover in a defined area, and we will have the other expert in that particular day. So from 4 o'clock same on the coming Sunday, we will again keep our edition 2. So with this, I will request Dr. Kole to proceed.
So good evening, everybody. Without any wasting of time, we can start our program directly. And the idea of organizing this program, that we can be updated with the recent guidelines and guidelines of our West Bengal government, ICMR also, and also some international guidelines. I'm sure that with these webinars, we'll be able to learn a lot. And we have told earlier that this type of webinar will be organizing on a regular basis. And now I will request Dr. Arindam to start his deliberation. Dr. Arindam, please.
Actually, I started before all of them, so I would be very short and precise in this part, because there are a lot of things to understand, learn, and listen from other speakers. We have an unique situation. Obviously, this is, I'm telling everyone that this is a lifetime opportunity for us to showcase, to sort of show that what is the importance of critical care even in the community itself. And for the first time, I think people have recognized so many critical care physicians, what we do, how we contribute towards it, and as well as I was telling, that we are one of the very few specialities of the medicine or the medical sciences who are constantly working in this situation. And we would be, I think Dr. Kole will moderate in such a way that we will manage in our discussion in such a way. One is how to manage the COVID positive patients when we are managing, but also we need to understand that there would be a lot of patients who are either being suspected or are critically ill, negative patients also, and how to manage them in this COVID your scaredemic, I would call it, not pandemic, scaredemic now, right? How to manage them in that way. And regarding, we have in a long journey. We initially started with 1 or 2 patients, and now we are flooded with loads of patients. Just a minute. Yeah, we are flooded with loads of patients. And every day the numbers are going up, and as WHO has very rightly said that it is going to stay for a while. We tried everything that we Indians are immune by tuberculosis, malaria, and all this stuff. It didn't work. We thought the weather of India would kill this virus or inactivate. It didn't happen. Then came monsoon, then came all sort of theories, including smoking and all this stuff. It didn't work. So it's going to stay. And as there is a retrovirus element within the novel virus itself, it is to come up with an effective vaccine would be very, very difficult. And also whether we are going to have long-lasting immunity, that is also going to be a question mark. So where are we? So is it going to be a new normal, as we are saying. So what is normal? Putting up 3 masks, putting up all the visors or the goggles, PPs, switching off your AC, working here, and every time you're expecting you will catch up the disease itself because it's so contagious. And whether we end up in a quarantine center and at the mercy of some of the of our colleagues, or we have a cytokine storm suddenly after doing well in 4 to 5 days. That uncertainty is creating havoc amongst the healthcare workers, particularly the doctors themselves, right? And also to add up to it, there are a lot of confusion. Everywhere in the world, the protocols are changing in almost every alternate day. We are not very sure about what is going to be next change in the protocol itself. Supply of things are always difficult. The manpowers are now dwindling. We have now a unique situation in Kolkata where the nursing people are thinking of whether to continue or not because they are panicking, seeing what is happening to their colleagues, as well as we have to be very honest, we have not treated them well before Corona and also during the Corona itself. Both us, the healthcare people, as well as the common lay people. So there are a lot of issues which are coming up, but my take in this is that 2-3 observations. I will start. The tone of the things is that it is not that deadly disease that we have seen. We have. I think all of us will contribute later on. That a lot of times seeing the CT scan or the extent of the disease process in the CT itself, or hypoxia that the patient, or the happy hypoxia the patient is seeing, those sort of patients did extremely well, right? Judging by the initial situation, they walked to home, and some of the patients unexpectedly dived deep and didn't make it. And that part where the patients started doing badly, they have not given a lot of time. They died within first 6 to 24 hours, and there was nothing that we could have done to save that patient. They were not responsive to any one of the treatment, and that was a very refractory and rapidly down in shock. So that is the little intriguing situation. And the other part is that we are now used to all these PPs and others, but whether this is going to stay or not, this is the million-dollar question. So I would request our subsequent speakers to highlight on this, on those issues, that how you are using, what is your awake proning strategy, how you are using ventilations, if at all you are using ventilations, little bit what is your success rate on a ventilator or on a ventilated COVID positive patient, whether you have been able to get them out. We have seen some of the stories published in the newspaper, but we can share it here. What is the steroid strategy when you are using, what is the timing and all this stuff? And obviously there are people who we have started the plasma therapy enrollment in Kolkata, and many of our colleagues, particularly Medica, Apollo and Fortis, have used tocilizumab. I'm not sure about the government sector. This is, and we are, if Dr. Pole agrees, we are restricting our discussion to particularly critically ill COVID patients. So many of the COVID patients have done well only with the oxygen and observation, right? We are calling it 2O therapy, oxygen and observation. So in that case, requiring a little bit oxygen and observation. So I would request Dr. Kole to take over and then proceed with the other speakers. Thank you, sir.
थोड़ा कम है चाहे पता है मैनेजमेंट ऑफ कोविड बोल रहा है
Dr. Kole, Saurabh, please. Acha, one just request, Dr. Susud Bandyopadhyay, Dr. Kole, Dr. Susud Bandyopadhyay will join after 15 to 20 minutes. Okay. So I think Dr. Susut is definitely he will share his because of some commitment with his COVID duty. So what he assured me that after 15 minutes he will join and then he will take part in this discussion. Okay. So other speaker, you please continue. Sort of the.
Dr. Kaur, can you tell us regarding the exact scenario of number of patients, COVID patients in Kolkata, which we are treating in the different hospitals, both in the government sector and the private sectors, approximately?
Approximately, as of now, if I'm not wrong, around 2800 is closely the number that people have been tested positive, and our positivity rate is just below 4%. That means 4 out of 100 people coming positive when you are testing on a standard RT-PCR. So, which is little matching up with the national average of 4.02 or something of that sort. So 80,000 approximately patient has been tested, and out of that, around 2,000, close to around 2,800 people have come positive, and we have around 232 deaths, deaths which had happened due to directly or indirectly due to corona or comorbidities, or corona with comorbidities, whichever way you can say. So our death rate, if you see, is close to around 10%, right? But I would ascribe it, mostly it is not to be very worried. I would ascribe it to because initially we didn't do that number of testing. So this is the scenario, and we have now close to around 19 labs which are doing test both in, and there are 3 different form of test: is RT-PCR, your TrueNAT Mol Biotechnique, and some of the institutes have started the Gene Expert, the cassette or the cartridge based RT-PCR technique. So this is the situation right now, and and everyone else would tell about the number of beds they have kept for isolated COVID positive patients as well as the suspected patients.
I am just asking the number of patients are in intensive care presently with the COVID patient.
Okay, the number of
approximately.
Yeah, approximately. If you see, I will tell very specifically. Let us take that the numbers in government sector. Your MR Bangalore has close to around 22 beds, all full. Medical College around 10 beds full, 32. You have Amri Salt Lake, which is catering to around 20-25 beds full. Then Apollo, they have 6 or 6 to 8 ICU beds. Then your Medica has made almost now 24 beds. 14 beds is 40s. So my estimate, there has been no official declaration of that. My estimate, there would be around 70 to 80 patients who are in ICU with a clear positive demarcations, and there are equally number of people who are in suspicion, or maybe the first test has come negative. So anywhere between 100 to 150 patients are in your ICU situation in Kolkata at any point of time, this point of time rather.
Okay, so
Sir, if you don't mind, just I am introducing Dr. Saha. Dr. Professor Vibhuti Saha, he is our very senior teacher in the medical college, our postgraduate as well as undergraduate teacher. Not only that, he in this particular COVID area, he is one of the figures actually about the triaging protocol, how it will be for the state protocol. He is one of the key person, and he was also nodal, you can say nodal person for this program. And not only that, even every year we have seen that used to take a major part in the control during the time of dengue. He used to take part of the control of the dengue, then formulate defined guidelines, as well as directly he touch with each and every hospital to control that dengue. So considering the immense his contribution to the society, I must, we are very, I think, grateful that Sir is here to basically give his consent to be part of this discussion and program. So you can also ask some question to Sir also. Sir, please.
So thank you, Dr. Paja and Dr. Kole, for asking me to join you, because I am not a critical care person, but I love to be with everyone who is doing great service to humanity. And today, all of us know, and as Dr. Kaur was telling, Dr. Kole was also telling, we are in a very crisis time, and it's the testing of character of all of us. So I'll be talking on the current diagnosis and triage protocol as we are practicing in West Bengal. And I'll be restricting myself to the ICMR guidelines and the West Bengal guidelines only. So first I'll be talking on the diagnostic strategy. Well, all of us know, this is known to all of us, this is the SARS-CoV virus. You have the spike protein, which gives us a corona-like appearance, crown appearance. And besides, it has a membrane protein, envelope protein, and then in the RNA, there's nucleocapsid, and this is the genomic RNA. So this is how the SARS-CoV-2 virus looks like. We know that we had SARS virus earlier in 2002-3, and then MERS-CoV in 2010 to 12, later on also. And now we are having this since the end of last year. And this is in detail the structure of the virus. You can see here the spike proteins S, membrane protein, envelope protein, nucleocapsid. And you can also the outer reading frames. It has two outer reading frames, WRF1A and WRF1B. And when we are using, these are all useful in diagnosis. So I'm showing this because this is useful for diagnosis of the virus. So what is done, whom we are testing, all of you know, so I don't need to repeat, I'm quickly just telling you all, this is from the ICMR. So that international travel is not there now, so this travel part is now gone. So all symptomatic contacts of the laboratory confirmed cases, all symptomatic healthcare workers, all patients who have severe acute respiratory illness, asymptomatic direct and high-risk contacts of a confirmed case, they have to be tested between day 5 and day 14. So if there's any healthcare worker who is exposure in the test of two sense of that term we'll be explaining later on, then he or she should be tested on day 5 and then on day 14. And in hotspot areas or in cluster areas, they are all the ILI, symptomatic ILI persons, influenza-like illness persons, they are tested. So these are the people whom we are testing. This is a specimen referral from, I think, the people who are testing, sending samples. They know you have to fill a few details, the name, age, sex, residence, all those things. And Aadhaar number is an important part of them. What specimen you are sending, because you may be sending the throat swab or nasopharyngeal swab, and in your critical care areas, you'll be sending BAL or the ETA. So these are the samples, the date and the sample ID, and you have to give detail of the person, what is the contact level, what is the current status of the respiratory infection, if he's a SARI or not. Then again, history of travel and all those things. Then clinical symptoms and signs. What is the patient's presentation? Cough, breathlessness, sore throat, diarrhea. We know there may be diarrhea, may be a presentation, nausea, chest pain, vomiting, all those things. And then pre-existing medical conditions. This is again important. You have to mention that chronic lung disease, chronic liver disease, immunocompromised, malignancy, diabetes, heart disease, hypertension, anything else like that. If the patient is hospitalized, because you are sending the hospitalized patients only, so what is the date of hospitalization, details of the referring doctor, name, mobile number, email, etc. And then the test result is sent by the center who is testing them. So that result, the date of the testing, the result may be positive, negative, or equivocal. And so this sort of results, we are getting this. Regarding pregnant women, we know there's ICMR guideline that all pregnant women who are from the hotspot areas, they are to be tested within 5 days of expected date of delivery. So this is important. Any woman who is expecting a delivery in the next 5 days should be tested. And any woman who is from hotspot area, so they have to be tested. What are the other tests we have? You know, this RT-PCR test is taking some time. if you go by the protocol, they first extract the RNA, that is step 1, and then run the test. So this test, these two tests together should not take more than 10-12 hours. But because of very many reasons, there is unfortunately some delay in getting results. Initially, the results were being delayed up to 3, 4, 5 days. Nowadays, the government has given very stress on that. Someone is, please unmute. Someone is talking. Please unmute that. Someone is talking. Please unmute. So government is now putting a lot of stress on the testing. Nowadays, more than 8,000 tests are being tested every day. And now the CBNAT test, which is Cefidex, because we had CBNAT for tuberculosis. Now we have CBNAT testing for this SARS-CoV-2, which is a definitive test. So like RT-PCR, the CBNAT is a definitive test. And you have a screening test, which is a TrueNAT beta-CoV, where you screen for the presence of the coronavirus. So if it is negative, that excludes COVID. But if the result is positive, then it has to be confirmed by the RT-PCR. So this is TrueNAT beta. So these tests are being made available by some centers. The advantage of this CBNAT test is very rapid. You can get the result in 4 hours or 6 hours. So this is very rapid. You can decide. You have a patient admitted in a critical care unit with a severe acute respiratory infection. You need to know whether it's COVID or not. So if you can do a CBNAT, you can tell within 4-6 hours that it's a COVID case. And TrueNAT beta is also a screening test. So if the screening is negative, you know your patient is not a COVID patient. So that's this test will be add value to our system. Specimen collection, well, we are collecting 2 types of swab. This is very important. All of your residents must be trained to collect the specimen properly, because the collection of a proper specimen has a value on the bearing on the test result. Many times we are getting results which are specimens which are not quality specimens. So please train some persons who are confident to take the smears. This is very easy to take, the swabs. So we can take either the nasopharyngeal swab or the oral nasal swab or the oropharyngeal swab. The patient is leans backward and the person is doing it with full PPE. The person who is collecting the specimen, he puts in there's a VTM medium and there is a stick. So the stick is opened and is put in the nose first, nasal swab first, and then the oral pharyngeal swab. So both the swabs have to be taken, both the nasal and the oropharyngeal. And I repeat, please train some person, 2, 3, 4 people in your system, or maybe train all the residents who can collect the swab. This is very important. Rightly collecting the swab. So either the nasal swab or the oropharyngeal swab is collected, and then it is put in a viral transport medium. You can keep it in at 2 to 8 degrees centigrade, maybe up to maximum up to 72 hours, but it should not be delaying. It should be sent to the testing lab as soon as possible, so that you can get the report as early as possible, and you can decide on what to do with your patient. So these are the testing laboratories in the government setup. We are having testing centers. You can see the name of the list, NICET, and many of the government hospitals in Kolkata, as well as the districts, they're testing now. And it's very good to see there's a good number of private labs also testing, like Apollo Gleneagles, Tata Medical Center, and then PLS Hospital, MRI Hospital, Shuraksha, and Dr. Lal Path Lab. And this is a need of the day. Arindam was telling, Dr. Kaur was telling in the beginning that our mortality rate is a little more high because we're testing less. Fortunately, the testing has increased and we have to increase it more. Now it is more than around 8,000 plus per day, but we should be targeting more. And as the more testing centers, government is already trying to set more testing centers in other medical colleges. Also, some of the private centers should also come up, so that if we test more, we know that we can diagnose the patients more quickly and we can do specific treatment for them. Now talking about the triage. How do we triage? First, I'll be talking about the COVID hospitals. Some of the government hospitals in Kolkata as well as in districts have been designated as COVID hospitals, and also some private hospitals like AMRI Salt Lake, and also Disan and some other hospitals. As I learned from you that AMRI is also doing, and also Medica is doing, as you said. So we have some designated COVID hospitals. So what is the protocol for the COVID hospital? You all of you know those, just repeating all of them. So we'll be having an outdoor with them, where we'll be triaging the patients with fever and respiratory infections. And all the patients who are coming to fever clinics must be wearing a face mask, or you should be providing them with that. We should be keeping more than 1 meter distance. We will be using appropriate PPE. I'll be showing you what are the PPE. You must be knowing, I'll be just repeating. And avoid face-to-face sitting. This is very important. If the patient is sitting like this, you sit on that side so that the patient does not breathe directly in your mouth. This is very, very important. So avoid sitting face to face with the patients. And of course, the patients must be wearing 3-layer surgical mask. You should not be allowing patient parties unless the patient is very sick, so that someone has to bring them. And patient will not be taking any phones with them in the wards. That's a protocol for the government hospitals. And the government hospitals are supposed to be helpline to communicate with the relatives, because once the patient is admitted, the patient is not provided mobile phones in the government hospitals. I don't know what you are doing in private hospitals. I personally don't have any objection in giving mobile phones to the patients, because that will help keep them in better mood and they can communicate with with their family relatives. But this is a hospital decision to be taken by you. And the lift should be there, a separate lift should be there to take the patients up, and they should be placed in single rooms. You are doing all these things, and if you don't have single rooms, they should be placed sufficiently apart, preferably more than 2 meters. And paperwork should not be done inside the wards; they should be done outside. And the patient should not be moving out of the moved out of the system for unless it's very medical risk, because that will carry the infection the other part. And environment has to be sanitized with 1% sodium hypochlorite frequently, at least thrice a day. And the food service, laundry, utensils, and medical waste, their protocols, and you'll be managing them accordingly. The healthcare workers should refrain from touching their nose, mouth, and eyes. This is very, very important. Many of us have a habit of putting our fingers in the nose or mouth. We are now in COVID era, so this habit should be going. We should not be touching our nose, mouth, or eyes with the fingers. This is very important. And also, we should be using gloves so that we are not touching surfaces where the virus may be there. We should be practicing hand hygiene always before touching the patient, before any procedures, after exposure to a body fluid, and after touching a patient, and after touching the patient's surroundings. So every time you should be practicing hand hygiene. Hand hygiene, hand hygiene, and hand hygiene should be the rule of the day. And this is alcohol-based hand rubs, all of you know, or if it is visibly soiled, you should be using soap and water. And after examining every patient, we must be doing hand hygiene. So we may be having 10 patients in the ward. So please make it a practice to keep the hand sanitizer at every bedside. And after seeing every patient, you should be practicing hand hygiene so that you don't carry the bugs, or because all of them may be COVID, but some other bugs may be there. Some patient may be having some bacteria, other things. So from one patient to other, going from one patient to other, please practice one hand hygiene. Of course, you must be doing that. I just reminding you this too. And the full PPE, all of you know, the N95 mask, the eye goggles, and the facial shield. Then long sleeves gown, head cover, gloves, and shoe cover. And donning and doffing, I know that you have taught all your people to do the donning and doffing, but very correctly. And most important is the doffing, because unless we are doffing rightly, we are likely to get infection. So this is very, very important. Please set an infection control nurse or the officer in the hospital will look specifically at these donning and doffing areas. And in the doffing areas, of course, we should be having hand washing facility. And there should be separate donning and doffing area in each floor. So it's not that you are admitting patients in 3 floors. So with one PPE, go to all floors. No, if you are working in 1 floor, after completing a round, please doff. Then if you are to go to the other floor, please don again on that floor and see the patient. So that should be the protocol to carry. Otherwise, you can carry the infections to the wards. Level of PPE, all of you know. Just to remind you, as in the triage area, we are using N95 mask and gloves. In the OPD, again, you can use the patient party will be triple layer medical mask. In the emergency department, N95 mask and gloves. In emergency department, when you're attending study patients, severe acute respiratory infection, the full PPE should be there, because there can be aerosol production. In the isolation wards or the COVID wards, full set of PPE. In the critical care unit, all of them, doctors, sisters, technician, anyone who's coming in with a full set of PPE. And the lift services, these are important. The lift services should be, liftman should be using N95 masks and gloves. Laboratory doctors and technicians, they should be using full set of PPE. Sanitation workers, people who are sanitizing, they should be using N95 mask and gloves. Mortuary, because some deaths will be there, and in the mortuary staff will be handling the dead bodies, they'll be using N95 mask and gloves. Administrative officers, those who are working the offices, who are not coming to the wards, of course, they don't need to use any PPE. Now coming to other hospitals, because there are hospitals who are either working as non-COVID hospitals, or they're having non-COVID block as well as a COVID block. So their settings should be a little different. So this guideline now I'm telling is about healthcare workers and others who are working in non-COVID hospitals and non-COVID treatment areas of hospitals with the COVID block. These hospitals should have a triage and holding area for people with influenza-like illness, and these patients should be managed in a different place than the other common outpatient department. This is very important to have a separate area for these ILI patients. So what PP they should be using this non-COVID hospitals and people who are non-COVID areas? Well, their risk is less. So in the help desk, they're using triple layer masks and latex gloves. Doctor chamber, triple layer mask and latex gloves. And the chamber of the ENT doctors or ophthalmoscopy doctors or dentists who are in more risk, so they should be using the N95 mask, gloves and the latex gloves and face shields. For pre-anesthetic checkup, N95 mask, gloves and latex gloves, and pharmacy counters, triple layer mask and latex gloves. Sanitary staff, they have a mild risk, so triple layer mask and latex gloves. So as I said, they should be having a separate holding area and triaging area for the ILI patients. And the inpatient department of these non-COVID hospitals, well, then the wards, there should be, they are mild risk, so they'll be using like mild risk patients. ICU, well, they have a moderate risk, so the N95 mask and the attire should be there. In the critical area, when the people are doing dead body packing or the patient died, the risk is less, so there'll be low risk cases. Again, in the dead body transport, they'll be using less risk like areas. Labor room, there should be, unless the patient, you need to take history where the patient is from. If the patient is from a containment zone or a red zone, then they should be using N95 mask. Otherwise, the normal triple layer mask, face shield, and sterile gloves and coveralls. OTs who are performing surgery under GA, triple layer mask, face shield, sterile gloves and goggles. And if there is aerosol procedure, then there should be a N95 mask. Sanitation workers, well, they'll be using triple layer mask and the latex gloves. Emergencies, well, these non-COVID areas, or normal emergency cases, mild risk, so they'll be using N95 mask. But severely ill patients who are having SARI cases, patients, they have a high risk, so they should be using N95 mask and other things which should be there present. Laboratory, again, in the laboratory, in the samples who are non-respiratory samples, mild risk, so normal surgical mask and gloves and all those things. And respiratory samples should be using, they should be using N95 mask. Radio diagnosis, blood bank, mild risk, they should be using normal surgical mask and gloves. Laundry people, mild risk, they'll be acting accordingly. And kitchen staff and other stuff, they should be using like low risk area, so surgical mask. And pre-hospital ambulance, people who are bringing the patients to us in the non-COVID areas, they are, if they are non-COVID cases, they are low risk cases, then they are triple layer mask and gloves. But if they are bringing a SARI patient, because SARI patients can be a high risk case for COVID, so full PP, that is N95 mask, coverall, and everything should be there. And the driver is a low risk, so he's sitting in a cabin in the front, using a triple layer surgical mask and latex examination gloves. So we should be remembering that PP should be donned and doffed properly. This is very, very important. And all of you should be having infection control nurse and officers. This is a very, very important part. If we neglect this, we are going to put ourselves in trouble, because if anyone in the system is infected, all of us run the risk of getting infected. So please have infection control nurse in all the systems and make sure that people are practicing hand hygiene and patients should be masked. And finally, if in a hospital which is supposedly dealing with non-COVID patients, but they are getting somebody is admitted with some other problem, like few days back it happened, some patient was admitted to hospital with a hemorrhagic CV. So he was, people thought it's a normal usual hemorrhagic CV. So patient was being treated usually, and now later on the patient started having fever and then tested for COVID and found to be positive. This is happening everywhere. So nowadays we say every patient should be considered as COVID unless it is proved otherwise. Please make our practice like that. Every patient should be considered as COVID unless proved otherwise. So if some patient is diagnosed as COVID in a non-COVID hospital, what should you do? The patient should be given isolated, put in a sent to isolation ward, but patient should be given appropriate level of treatment. If it happens in ICU, the patient has been admitted with a supposedly non-COVID state, and the patient now is now turned out to be COVID, the patient should be cared for in the ICU itself, because he's depending on the so many things, machines, better than me, and you can't transfer the patient out. And so what you can do, you need to get in touch with the health department or in your system, so that you transfer the patient to a designated COVID hospital. So till the patient is with you, you should be taking full care of the patient as is appropriate for the level of his illness. And in that case, you just check with your healthcare staff, because many of your staff might have been exposed. And in this context, please remember that by definite exposure, it is meant that somebody who is within 1 meter distance of the patient for 15 minutes or more without any protective gear. I repeat, within 1 meter distance of the patient for a duration of 15 minutes or more without any protective gear. So if it happens like that, you are with full attire, full PPE, the patient has a mask, you didn't know that the patient is a COVID patient. I thought he's a non-COVID patient, and now subsequently the patient is diagnosed to be COVID patient. You don't need to go to quarantine. So your infection control officer in your hospital must be checking every details, because we are seeing that in many hospitals, say 30, 40 of the healthcare workers, including some doctors, are going to quarantine and the hospital is stopped. This should not be happening. We should be, as I said, we should be practicing like that every patient is COVID unless proved otherwise. There should be a definite hospital protocol for all the patients. And if somehow a patient in a non-COVID hospital turns out as positive, the infection control officer or the doctor in charge or the nurse in charge, nurses can be very powerful. If you are we can see that there can be very knowledgeable nurses, we can be given these duties. So they should be checking with the details of the patient, and every ward you should be having a registry. This is again important. Who are the doctors who are going for duty? Who are the sisters who are going for the duty? Who are the GDS who are going for the training? Who are the staff who are giving the food? So you should be having a registry so that you will note. So if a patient is detected as a COVID in a hospital, you check the list. Who are the people who have been exposed to this patient? And usually these patients, they start spreading the infection 2 days before the onset of symptoms. So if someone has been exposed 5 days before the onset of symptom, probably he doesn't need anything. So 2 days before onset of symptom, the people start excreting the virus. So we should be taking care of that also, and we should be also taking care of whatever the situation. An infection control officer will decide that who are the people who have to be tested, and all the healthcare workers, they should be tested. All the healthcare workers who have been definitely exposed should be tested within 5 days. And if they are doing well, and also in between, if they get symptoms, they should be tested. And if they are asymptomatic, they should be tested again at the 14th day. And after that, their quarantine is over, and they can come back to the healthcare system. So I'll end by saying that COVID has come to stay with us, and we should be learning. All of us should learn to live with COVID. So it's a when you go out for your duties for the day, please apply your mind that what are the things I'm going to do.